Hello, my name is Desiree Creekmore, and I'll be doing the webinar today on evidence-based practice and patient safety. So we'll start by talking about evidence-based practice. Just a basic overall of what it is. Evidence-based practice is care practices that are based on the most current research and clinical expertise. It integrates the best research evidence, knowledge from clinical experts, patient preferences, and sort of mashes them all together and aims to give the most consistent and best possible care by creating clinical guidelines that are based on current evidence. We use evidence-based practice in the current practice setting by getting a compilation of all of the evidence that's out there and putting it together and ensuring that all of our practices are based on the most current research, not by one person, but by a group of people, by many people, that the research is valid and reliable research and is appropriate for our practice setting. Now, as we talked about in class, we've got the ABCDEs of evaluation of evidence. When considering which data to use for evidence-based practice, please ask the following questions. Authority, how well known is the author? Is the author a well-regarded name, someone you recognize, someone who's been in practice for a long period of time? What are their qualifications? Does the document that you're working on or working with in consideration for this evidence-based practice project contain an email address? We also look at biases of the research that we're looking for. Does the site or document try to persuade rather than inform? What organization sponsors the site or document? Is that organization reliable? Is the page actually an ad disguised as information? That happens frequently in practice, unfortunately. Then we'll look at citations. Are full citations given to support the work? If so, did you compare the author's content with the content in the citation? And how about dates? How recent are the dates that are listed? Does the information you need demand more current data than is given in the document currently? Or is there a seal of approval posted? For example, the Health on Net Foundation gives a seal of approval to websites that meet high standards. TrustE, http://www.trustee.com, gives a seal that guarantees privacy, for instance. Whether you use websites or print references, use the following strategies. Always try to verify information with the primary or original sources, ensuring that the citations are appropriate. For example, cite this book, the Alfaro Lafere book that we use in class, directly if there's no credit to another author. But if I give a citation for a specific sentence or idea, check that citation since it's the primary or original source. If you're unsure about the information that you have, compare it with at least 2 other reputable sources on the same topic. Remember, more than one source, more likely of the course. And then number 5, we look at evolution. What is the evolution of the work? Is it a seminal study, or has the information been updated recently on the website if that's where you got it from? Have there been any replication studies, or is this just one study that gets a certain number of research, just one study that gets a research evaluation or that finishes the research and then no other studies can repeat that information? The A-STAR model, it shows the Academic Center for Evidence-Based Practice, STAR model of knowledge transformation. This is something that we use when we're implementing evidence-based practice in the clinical setting. In this model, research evidence moves through the following cycles and then is combined with other knowledge and integrated into practice. So we go through the discovery portion of the STAR. That's where you have that spirit of scientific inquiry that we talked about in class. New knowledge is discovered through traditional research and it then moves over to the next section of the STAR, the evidence summary. A single meaningful statement of the state of the science is developed in this portion of the STAR. It's a complex task. It takes a lot of critical thinking on the part of knowledgeable experts to go through that part. Then translation. Evidence summaries are translated into practice recommendations or clinical practice guidelines and integrated into practice. Recommendations are made through these knowledgeable experts to change care standards, create clinical pathways, create protocols or care protocols and algorithms that we use to make sure that the best, most scientific evidence is used to ensure our patients are getting the best quality care. Number 4 is integration. Individual and organizational practices are changed through formal and informal channels. And then evaluation. How does this evidence impact our patient health outcomes, our provider or patient satisfaction, efficacy, efficiency, and economic costs? We continue to examine those throughout the entire time that we're employing evidence-based practice. Then we have CPGs. What are CPGs? These are our clinical practice guidelines. They're recommendations for how we manage care in specific diseases, problems, situations. How are we best going to manage care for smoking cessation, or for neonate umbilical cord care, or for things like patient education for COPD patients, those kinds of things. CPGs are developed for specific use and are designed by a collaborative panel of clinical and scientific experts or knowledge experts, people that work in the field and have been doing this for quite a while. When the scientific evidence is sufficient, meaning we have enough research available to us, then and we have other sources of knowledge like wisdom gained from clinical experts or specific case studies that we may notice. We bring all that together. We fill in gaps here and there where we need to, where the research evidence doesn't necessarily support everything that we want to employ, and then we create evidence summaries and CPGs. They're the essence of evidence-based practice. We use all of these things to provide mechanisms for fulfilling our social responsibility to provide the best, most quality care in the most effective and affordable way. You'll find many helpful links at different resources such as www.acestar.uthscsa.edu. And then how do we encourage evidence-based practice? There's many different ways. We go through different websites. There's lots of different websites like the AHRQ, the Cochrane Library, National Guideline Clearinghouse. In your Lefevre book, the Alfaro Lefevre book, you'll find on page 142 a discussion of some of these different websites and rating scales for evidence-based practice, how we can use it, those kinds of things. How we use these websites is sort of just go to the websites, identify what kinds of things we're looking for, and then identify what level of evidence you have for them. You know, some of our most appropriate levels of evidence are the level A, where you'll find on the Cochrane Library they use almost all level A type work. It's all meta-analyses, lots of evidence-based practice, things that have lots of research to support those practice guidelines are in the level A type rating scales for evidence-based practice. It's all in that library. You have lots of resources. You can go to all of these websites and identify many things that you can work on in the clinical practice area. When we transform research into practice, one of the things that we really encourage is supporting a spirit of inquiry and then promoting this culture of inquiry. We do lots of things to encourage and promote the spirit and the culture that's needed to ensure that evidence-based practice is upheld. A lot of hospital settings and other areas where we practice, because not everybody practices in the hospital setting, but lots of different settings go through, and they have ways that they collaborate with the different healthcare team members, whether you work one-on-one with doctors or in large group settings, such as when we're in the ICU, we work with big collaborative teams with dietary, respiratory, physical therapy, occupational therapy, the physicians. We have every single kind of physician that can come out there. So we have a large healthcare team that gets together and works together. Unfortunately, just one nurse isn't going to make all of this happen. Just one nurse isn't going to be able to promote evidence-based practice or encourage the spirit of inquiry. One nurse can get other people involved, especially when you've got great leadership skills, but it takes a lot of work to actually get evidence-based practice going. It takes quite a bit of work. So one of the things that we do is really encourage curiosity, encourage that inquisitive thinking, encourage asking questions. Asking questions is a hallmark of clinical thinking or critical thinking. The new nurse that comes out that continually asks questions is the nurse that's going to learn quite a bit. The new nurse who comes out and doesn't think she needs to ask anybody questions might end up becoming a dangerous nurse, unfortunately, sometimes. So some of the things that we do in the hospital setting or in the outpatient setting, just depending on where you're going, is we'll encourage monthly literature reviews. Those are meetings that we get together with other disciplines sometimes, or at least other nurses, where we get together and we look at lots of different evidence for maybe one topic to see if we can identify areas of evidence-based practice that we can incorporate into our facilities wherever they may be. We can't necessarily do all of this by ourselves. We have to have a little bit of help. So these monthly literature reviews are a good way to encourage all of us to collaborate together and ensure that we can get enough evidence to support our cause as possible. Sometimes we also are engaged in things like journal clubs. Journal clubs are just where we get together and we get maybe 1 or 2 articles and we read them over and discuss them, and then maybe afterwards we'll do a literature review to see if there's any additional literature out there to support the cause that got us there to begin with. You can also encourage the use of EBP by using care maps or making care maps that are made using CPGs or the clinical practice guidelines that the experts in the facilities or experts in the field come up with. You can go to websites like the AACN and national organizations for different areas of nursing and identify what maybe their clinical practice guidelines are for specific tasks, for specific problems that we have in nursing or in healthcare in general, and find out what everybody sort of sees together and see if there's any ability to make like a care map. A good example of this is in the hospital we have care maps for heart failure patients or care maps for STEMI patients, care maps for COPD patients. Basically, it's a map of things that need to be done before the patient is discharged from the hospital to ensure that they have the best quality of care. I know they use these very frequently in pediatrics. Phoenix Children's Hospital is outstanding at creating and using care maps. And then we also get together and we collaborate with other members of the healthcare team to try and encourage evidence-based practice. We get together and discuss our thoughts and our feelings on it. We get together with other disciplines. Like I said, sometimes we invite them to our literature reviews. Sometimes we invite them to our journal clubs. Sometimes we invite them to meetings where we discuss CPGs and discuss policies and procedures that we have at the facilities or in the outpatient settings that we may work in, those kinds of things. And when we discuss EBP, one of the things that we have really focused on in healthcare is quality improvement, and they sort of go hand in hand. We try to implement evidence-based practice in quality improvement as much as possible. So you'll find that a lot of evidence-based practice is specific to patient safety issues that we have within the inpatient or outpatient setting. So that being said, one of the core competencies from the Nurse of the Future competencies is quality improvement. Quality improvement is just identifying errors and hazards in care, understanding and implementing basic safety design principles such as standardization and simplification, continually understanding measures of quality of care in terms of structure, process, outcomes in relation to patient and community needs. And then we design and test interventions to change processes and systems of care with the objective of improving quality. Patient safety in relation to quality improvement is really important. When we talk about safety, we're talking about the freedom from accidental injury. Not all patient safety is specific to errors, but errors are fairly common when we're discussing patient safety. It's something that just automatically comes to our head, is the errors that happen all the time. But safety and errors, safety is a little bit different than error in terms of the definition. Like I said, the definition of safety is freedom from accidental injury. Error is the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. Errors are directly related to outcomes, but they don't necessarily change outcomes all the time. Medication errors are sort of at the forefront of patient safety issues. Obviously, I mean, it's something that we talk about in class frequently. It's something that we talk about in healthcare all the time. You hear it all over the news. It's sort of at the forefront for all quality improvement. Other types of errors and patient safety issues do occur and are also very important in keeping patients safe. We have communication errors, for instance, and communication errors are actually listed from the IOM as the primary source of errors, not necessarily an individual failure, but just communication errors in general. We also have issues with falls. That's a patient safety issue. We have problems with wrong site surgeries or wrong site problems when it comes to procedures that we do in the hospitals. We have issues with infectious diseases, unfortunately, in the hospitals. Safety should also be included in every care plan. It's a problem that everybody has. It's a problem that everybody in every practice setting will notice at some point, and it should be included in every care plan across the board. Some patient safety terms that you need to know that you'll discuss more in class if you haven't already is the failure to rescue. Failure to rescue is the inadequate or delayed response to clinical deterioration in hospitalized patients. An example of this would be the patient who's in a telemetry or a medical surgical unit who is showing early signs of shock. If the nurse doesn't realize that the patient's showing those early signs of shock and the patient ends up getting to the third stage of shock and subsequently ends up with multi-organ system failure, then you unfortunately were unable to rescue your patient before they ended up with a problem that could potentially be fatal. A near miss is identified as the National Safety Council as an unplanned event that did not result in injury, illness, or damage, but had the potential to do so. Only a fortunate break in some chain of events prevented that injury, fatality, or damage. This unfortunately happens quite frequently. An example of this might be you were about to give a medication and you found that it was the wrong medication, or you were about to give a medication and you found that the patient had an allergy and nobody had caught it right until that point. The Joint Commission defines a sentinel event as an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. Serious injury specifically includes loss of limb or function. The phrase "or the risk thereof" includes any process variation for which a recurrence would carry a significant chance of a serious adverse event. And then root cause analysis is a comprehensive and systematic methodology to identify the gaps in hospital systems and the processes of healthcare that may not be immediately apparent that may have caused a problem and which may have contributed to the occurrence of whatever event might have happened. So the root cause analysis is what you do when you have one of these problems to identify a gap in the system in which you can potentially, hopefully, fix. Changing the culture of healthcare is something that's very challenging, unfortunately. There's a safety culture out there, and a lot of people have this identity. They still think that the blame game is happening. They still think that they're being blamed for a problem that may potentially be going on. In healthcare, we're trying to get away from the blame game. We're trying to change the culture. We're trying to get away from people saying, well, you did this wrong, so you're going to get fired, or thinking that that's what's going to end up happening if there is an error that occurs under their watch. Unfortunately, error is human. To err is human. It's something that we all do, unfortunately. We will make errors at some point just because we are just human. So rather than blaming each other for problems, specifically because problems aren't necessarily related to human circumstance, a lot of times they're more related to system circumstance. So now we're going from this blame game that we used to have, or that the hospitals and the outpatient settings used to give this sort of thought about, that the nurses would not want to say that they had a problem. They might get punished if they had a problem. Now we're going from that sort of blame game, that sort of culture, to the just culture approach. Just culture is a non-punitive, fair and just system. Managers actually go about and talk to staff about the risk factors to safety and contributing factors to errors. They don't necessarily say, oh my goodness, you just had this error happen, it's all your fault, you're going to get fired, or something along those lines like they used to. Now they have this non-punitive type of action. All staff are still accountable for their actions, and if you do something that's malicious, then of course you'll be held accountable for those actions. But most of us don't go to work to be malicious. Most of us don't go to work with the intent on harming somebody. So all staff, they're still accountable for their actions, and they're expected to engage in activities that will improve the processes of care, but systems should be put in place to allow staff to report medical errors and patient safety concerns, including voluntary near-miss reporting, to encourage a culture of safety and a just culture approach. So we have already in most inpatient and outpatient facilities things like incident reporting. That's a form of reporting issues in patient safety. We also, a lot of facilities have already implemented near-miss reporting, where when you find a near-miss happen, you can go and report that as well, so that maybe we can still take a look and see if there was a problem in the system somewhere that can be fixed, or a gap in the system somewhere that can be fixed. Speak Up is a joint commission and Center for Medicare and Medicaid funded program that urges patients to take an active role in preventing healthcare errors by becoming involved and informing participants on their healthcare team. The Speak Up program itself has brochures and posters and animated videos, infographics that can all be downloaded for free and used in facilities, but it encourages people to speak up if they have questions or concerns, to pay attention to the care that they get, make sure that they're getting the right treatments, the right medicines, the staff members are doing things that they need to do in the hospital setting, like washing their hands. It encourages patients to educate themselves about their illnesses. That's something that sometimes we need to help veer the patients in the right direction, because some patients don't necessarily know how to educate themselves appropriately. It encourages them to ask trusted family members or friends to be their advocate, to know what medications they take, why they take them, what risk factors they have that might make them more at risk for problems due to those medications, and also side effects and adverse events that may possibly take place with those medications. And then also making sure that they know about the medications and the dosages that they take, and what to expect out of the nurse to try and help prevent medication errors, because it's a common healthcare mistake. They're also encouraged to use hospitals, clinics, surgery centers, other types of healthcare organizations that have been carefully checked out, such as areas that are certified by the Joint Commission. That's why a lot of the hospitals and nursing homes are going through and trying to become Joint Commission certified now again. There was sort of a wave of going away from it at one point, and now all of them are starting to try and become Joint Commission certified again, because the patients know that if they're Joint Commission certified, then they meet the Joint Commission's quality standards, which are a little bit higher than maybe the state standards. So because patients are encouraged to use these centers or healthcare organizations that are carefully checked out, the patients, most of the hospitals and outpatient centers are looking towards getting those higher certifications now. And then it encourages the patients to participate in all their decisions and all their treatment needed for their healthcare stay. The patients traditionally were not participants in their care. It was just the doctor and the nurse making sure things happened that needed to happen. Now we're actively trying to encourage patient-centered care, in which case we can't provide patient-centered care if the patient isn't involved in all of our decisions about care and treatment. Unfortunately, one of the biggest problems that we have, as we stated before, is medication errors. It's one of those things that we see a lot in the healthcare setting, unfortunately. Now, medication errors aren't usually just because the nurse didn't follow her 6 rights. They didn't follow the 6 rights, so they had a medication error. Unfortunately, most of the medication errors take place in the ordering process. Probably, I wanted to say that the book states upwards of like 60-something% of medication error actually take place in the ordering process, not necessarily in the actual medication administration process. But as a nurse, what we can do is ensure that we know our 6 rights: the right patient, right drug, right dose, right time, right route, right documentation, all occur, okay? When it comes to medication errors, though, like I said before, a lot of problems that we have with medication administration and medication errors are related to the actual administration process itself, or the system, not necessarily just that nurse who's not paying attention. Usually it's a system problem. So unfortunately, as nursing students, a lot of times we don't have the ability to understand the actual process. We, as nursing students, go into the hospital and we perform the task of medication administration. But medication administration has a lot more to it than just that task. It's a lot more than just looking up the medication and giving it to the patient. But nursing students don't tend to have a lot of experience with the process with the system. So there's a lot of different steps in the medication process. You have the prescribing step, where the physician is prescribing the medication. Then you have the dispensing step, where the pharmacy dispenses the medication to the unit that you're working within, or the organization you're working within. Then you have the administering step, and that's where the nurse comes in, where the nurse comes and actually gives the medication. And then after you actually give the medication, there's 2 more steps in the medication administration process that sometimes don't always get noticed. You have the monitoring step, where you monitor the patient for the effects of the medication or for side effects of the medication. And then the managing step, in which you manage the care of the patient after giving the medication. So there's a lot more to it than just actually performing the task of giving that medication. A lot more to it. Students, like I said, often lack the information about that system. They get very focused on the task itself, and they might miss an error in the system somewhere else. Like I said before, the actual prescribing step is where most of the medication errors occur. So as student nurses, we need to be aware of that. There are other things that impact students and nurses alike and can cause errors in medication administration, such as non-standard dosage times. Unfortunately, not all medications are at standard dosage times, and if they're not, sometimes they will go missed. Most of the medication errors are actually errors of omission, so you forget to give the medication, or you didn't realize the medication was due, so you didn't give it. You can also have errors in documentation. Maybe the night shift nurse or the day shift nurse before you came on forgot to document a medication, so that medication gets given twice, or maybe they didn't realize that it was there, and then you didn't want to give a second dose just in case the night shift or the day shift nurse before you didn't have or gave that medication and you just didn't know it. Sometimes you end up with partial drug administration, where you only give part of a drug instead of the full drug. Maybe the dosage was wrong, or maybe the order was incorrect. Holding and discontinuing meds can also be a source of error. If you hold a medication, one of the things that a lot of students don't realize, and sometimes I don't think nurses in practice even realize, is that when you hold a medication, you have to have a specific reason for holding it. And then after you hold it, you have to document why that medication was held. And subsequently, because it's sort of practicing outside your scope if you're not giving medications that are supposed to be given without identifying or without discussing it with the physician as well. So a lot of nurses don't realize that if they hold a medication and they're not able to give it at a later time, because let's just say we have a medication for blood pressure and the patient's blood pressure was a little bit low, so we held that medication at that time. If we don't give it a little bit later after the blood pressure has increased a little bit, then it's our responsibility to discuss that with the physician to make sure that we don't have a medication error. Sometimes you also run into the problem of discontinued medications, where the physicians will discontinue a medication and they won't want it given, but you won't realize it until after it's administered. We don't see that as much anymore now that we have computerized medication administration, but in some areas like the emergency room where they don't scan the medications and whatnot, sometimes you might have an issue with that still. Monitoring issues are also a big problem, where nurses don't realize that, hey, I need to take that blood pressure before I give that medication, or I forgot to get a blood sugar before I gave them their morning dose of whatever anti-hyperglycemic medication they were on. And then they also have issues with non-specific doses. Just give one pill or one capsule, but there's no specific dosages on there. And oral liquids can sometimes, unfortunately, be given in the wrong route, such as IV instead of PO or IM instead of PO. Sometimes that can cause a problem. And then when errors occur, what do we do? As nurses, there's lots of things that we can do, but what do we do? It's really important that the first thing we're obviously going to do is go and assess our patient, right? That's part of the nursing process. One of the first things you almost always do is assess your patient. If an error did occur and the patient got the wrong medication or something similar, we'll go and assess our patient and see what's going on. After we do an assessment, we're going to have to tell somebody. The first person that you really need to tell is the patient's physician. And that can be really hard. And that's an area where a lot of nurses have a hard time with that communication. Because as a nurse, you feel guilty when you make an error. You feel guilty that you did something wrong. And unfortunately, sometimes it happens. The worst thing that you can do is keep it to yourself. Now, sometimes, let's face it, not all physicians are good communicators, and you might run into a physician who will yell at you or something along those lines if you gave the medication wrong. But note that because we're trying to go to a just culture type of society, all of your errors should be taken as learning experiences. They should not be taken as punitive experiences. You should not be yelled at, but you need to know that there was a problem, that there was an error that occurred, and the physician needs to know as well, especially if it's an error that could potentially cause harm to the patient, which most medication errors can. So you're going to have to talk to the physician at the very least. And then we'll want to fill out an incident report because we want to go through and ensure that the right people know that this happened. Now, by the right people, yes, unfortunately, a lot of times it goes to your manager, and that's something we're all going to have to deal with. But again, it's non-punitive. We have a just culture society. You have to do an incident report so that managers, pharmacists, physicians, experts in the area figure out where the gap in the system happened so that they have the ability to do that root cause analysis and figure out what kinds of problems occurred, what could have prevented this error. Maybe there's something simple that we could have done to prevent it so that in the future when we go on and look at these errors, we can say, hey, we saw that this was the problem. Let's go ahead and fix it. Let's implement this change to try and fix this problem so that nobody else runs into this error as well. Variance reporting is very, very important. It allows us to sit down and look at that stuff. It allows us to sit down and identify areas where we can improve. And sometimes you can't just do it by yourself. That's why we do this variance reporting. Just like evidence-based practice, it takes a whole team of people to collaborate to identify gaps in the system sometimes. So variance reporting allows these other people that belong to the system to also have a good look at that error and identify ways in which we can prevent it from happening again. So this was the content clinic for topics 11 and 12. If you have any further questions, please connect with your faculty member. And if you need any additional clarification, please connect with one of them. We'll be happy to help you. All of the content clinic sessions can be accessed through the Student Success Center at the website that you've gone to see this one. Thank you for coming and enjoy your day.